Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echovascular, general, high-risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency. Welcome. Today we are talking about the good old Tetralogy of Fallot, TOF. There's a lot of different ways to look at this, and one of the biggest questions is pink versus blue, right? So it's a pink TED or a blue TED. And I'm hoping that you'll get relief to know that we can't always tell in utero. Sometimes we have to wait till after they're born, but we'll go over a few notes that I have here in regard to tetralogy. This is one of my favorite things to find, and I get so excited, and I'm not sure why, but it's just a fun thing to kind of dissect and look at and try to figure out, I think. So there's four main characteristics of tetralogy of Fallot: the subaortic malaligned VSD, the aortic root that overrides the VSD, the right ventricular outflow tract obstruction, and there's varying degrees of this infundibular and valvular pulmonary stenosis. And there's right ventricular hypertrophy, but this you don't typically see in utero. It usually develops postnatally. So it's important to know that TOF is a strong association with nuchal translucency, with an increased nuchal translucency and DeGeorge 22q11.2 deletion. And if you were at not this past year's STMS, the year before, I always thought DeGeorge was 22q11.2 deletion, and I learned something at STMS about DeGeorge, and it's 22q11.2 deletion. Just as a side note, you never know what you're gonna learn at all those STMS conferences. They're just so awesome. So when you have a pink TED, you're going to have antegrated flow in the ductal arteriosus. It's going to go from right to left. But blue TOF, you're going to have retrograde flow in the DA, the ductus arteriosus, which means it's left to right due to the significant obstruction in the right ventricular outflow tract. So this is what's going to cause cyanotic newborn babies, right? And it results from postnatal ductal dependency. So when you go to your 3-vessel trachea view and you get one blue and one red, then you know when you get the pulmonary red and the aorta blue, you better start thinking tetralogy. So determining the aortic origin will help identify if this is a double outlet right ventricular obstruction, which is a type of a TOF. It's a type of tetralogy, but it's a little tricky, right? And so this is what I spend a lot of time just trying to figure out sometimes. If 50% of the aorta is over the left ventricle, if 50% of the aorta is over the left ventricle, then it's tetralogy of Fallot. If greater than 50% of the aorta is over the right ventricle, then we think double outlet right ventricle, okay? So let me say that again. If greater than 50% of the aorta is over the left ventricle, then we think tetralogy of Fallot. But if 50% of the aorta is over the right ventricle, then we think double outlet right ventricle. So there's three main subtypes of tetralogy of Fallot. You have tetralogy of Fallot with pulmonary stenosis, and this is the most common, right? This is what you're going to see a majority of the time. I think in literature it says 80% of cases. Then you have tetralogy of Fallot with pulmonary atresia. So you can still maybe get a little bit of flow through that pulmonary, but it's very narrow and it's very small. Tetralogy of Fallot with absent pulmonary valve. So remember, there's 3 types of main subtypes of tetralogy of Fallot. So some of the sonographic findings of the tetralogy of Fallot with pulmonary stenosis is you're going to check the ascending aorta, and if it points to the right fetal shoulder, wide angle between the direction of the ventricular septum and the anterior wall of the ascending aorta. You might also see the ascending aorta courses parallel to the ventricular septum, and blood drains from the right ventricle and the left ventricle through the VSD into the ascending aorta. The dilated aortic root can also be seen, but most of the time that's in the 3rd trimester. If you have a narrow PA, you're going to have possibly some branch attachments of the DA to the descending aorta. Instead of the V configuration with the aortic isthmus, the DA into the descending aorta is a very common sign. And the PA is typically smaller than the aorta. It's very narrow, but it's patent. So I'm trying to figure out how to explain some of this without diagrams, being that this is a podcast. So I'm just going to try to explain some of these. So I think it's important to note, earlier we mentioned that tetralogy of Fallot can be associated with extracardiac anomalies. 30% for chromosomal anomalies, 10 to 15% with the 22q11.2, and congenital anomalies of any kind of the anatomic organs. So it's important that when you do start to see these issues in the heart, that you're looking at all the organs. Remember, the kidneys, different things like that, all form around the same time the heart is formed. 83% of the time you have a patent foramen ovale atrial septal defect. The right side aortic arch occurs 25% of the time. A persistent left superior vena cava is 11% of the time. Atrial ventricular septal defect is less than 5%. The abnormal coronary circulation is less than 5%. And anomalies of the pulmonary venous connection is less than 1%. So just understand that when you start to see any kind of defect with the heart, you're going to start looking for a lot of other different anomalies. So I want to talk about kind of the decision-making process a little bit. When I see a VSD with an overriding great artery, I want to interrogate the pulmonary artery origin. So if the pulmonary artery origin comes from the right ventricle, then I want to figure out, what is the pulmonary artery size? Is it normal? Then we have just a malaligned VSD. If the pulmonary artery size is small, then we might have tetralogy of Fallot, or we do probably have tetralogy of Fallot. If it's really small, then we have pulmonary atresia with a VSD. But if the pulmonary artery size is large, then we probably have an absent pulmonary valve syndrome. And so I think these are things to think about when we're starting to evaluate, right? And this is our decision tree that we make. If we look at the pulmonary artery origin and no visible pulmonary artery, can't find it, then we think pulmonary atresia with a VSD. Back to the pulmonary artery origin from overriding a great vessel, then we think common atrial trunk. So again, if we have a VSD with an overriding great artery, we're going to interrogate that pulmonary artery origin, and we're going to check on its size, right? If it's on the right size, then we want to check the size of the pulmonary and where it originates. If it's not visible, it's most likely pulmonary atresia with a VSD. But if it's if it overriding the great artery, then we're thinking double outlet right ventricle or common atrial trunk. So I think that's an important decision tree outline that I will link in the show notes for you to pick up, and maybe that'll help you when trying to figure out tetralogy. So in the end, I don't want to make this really super long. I do want to just talk about some key points of the tetralogy of Fallot. It's characterized by subaortic VSD. The aortic root overrides and the infundibular pulmonary stenosis. You have infundibular pulmonary stenosis. Tetralogy of Fallot flow is one of the most common forms of cyanotic CHD. So when babies show up in the nursery and all of a sudden they're turning blue, that's one of the first things that nurses and doctors start trying to evaluate right away. The four-chamber view appears normal on a tetralogy of flow unless the VSD is so large and visible in this plane. So no, just because you have a normal four-chamber doesn't mean you have a normal heart. Please, please, please do the left and the right. So the tetralogy of flow is typically detected in the five-chamber view, demonstrating a perimembranous subaortic VSD, which makes it override. So that is the most common view that we start to consider the tetralogy of flow is the five-chamber view. The aortic root appears dilated in tetralogy of flow, especially in the third trimester. There's a strong association between an increased nuchal translucency measurement and the diagnosis of tetralogy of flow. And I don't know about you, but we're doing first trimester anatomies now at many of the sites that I've been to. And when I get a thick nuchal translucency, I immediately go to the heart. Immediately. And if I just can do one sweep from the four chamber up superiorly and see that the left and the right are crossing, I feel like I've gotten a lot of information doing that. So if at all, just attempt to try to get that four chamber sweep where you see the right and left crossing, especially with a thick nuchal translucence. So know that if you do see a tetralogy of flow, there's probably going to be associated extracardiac anomalies as well. You might also see a patent foramen ovale and an atrial septor defect, which are found in 83% of tetralogy cases. A right-sided aortic arch and a persistent left superior vena cava have been found in 25% and 11% of TOF cases. The rate of chromosomal anomalies is around 30% in tetralogy of flow. And the most common microdeletion is DeJord. 22q11.2 is found in 10 to 15% of fetuses. So the poor prognosis are signs of with tetralogy of flow is the increased deceleration growth of the pulmonary artery, accelerated growth of the ascending aorta. And of course, if you see reversal flow through the ductus, that's also pretty concerning. So sometimes they'll want to try to keep that ductus open, right? After the baby's born as much as they possibly can in order to help this baby out before it can get to surgery. So let's talk a little bit about double outlet right ventricle. The most common form of double outlet right ventricle is the aorta to the right of the pulmonary artery. So subaortic type VSD. Detransposition type of double outlet right ventricle. It's the right anterior aorta to the pulmonary artery. And this is the second most common type of double outlet right ventricle. They have VSD either is subaortic or subpulmonary subgroup called Taussig-Bing from the double outlet right ventricle. So the right there is a tetralogy of flow type of double outlet right ventricle. This is a rare form of the double outlet right ventricle, but there are normal relationships of the great artery, which will blow your mind when you see it because you think surely not. And the L transposition type of double outlet right ventricle, it's a rare form of double outlet right ventricle where the left anterior aorta to the pulmonary artery. So these are all the different types of double outlet. So once you figure out that this may be a tetralogy of flow, or if you feel like it's really covering greater, if the aorta is covering greater than 50% of the right ventricle, then we know that we're talking about double outlet right ventricle. And so then there's those subdivisions of the double outlet right ventricle that I just mentioned that you can start to help differentiate. So I think it's super important to remember excuse me, some of these subtypes and different ways to be able to evaluate it. Once you see it once, you'll almost always be able to pick it up. It just is to what degree is their disease process. And this is really helpful because depending on how far along they are, right? We want a big baby at delivery because we know they're going to be going to surgery. So we'd like to keep babies in moms as long as we possibly can, and so they can get as big as they possibly can. But we also know that there's some risk with that as well. So I hope there were some helpful tips to this short little tetralogy of flow. I wanted to do a podcast with a little bit more of a technical aspect to it. I think in the past, we've had a few general conversations on the podcast. And so a little talk about Tetralogy of Flow before we head into our Christmas holiday. I hope this was helpful. Please send me comments to let me know if this was helpful, if there was something I could add that you might get more help from. And I hope you're enjoying your December 2025. We will talk with you next week. And remember, it's all about the frequency. And what are you doing this holiday season in 2025 to increase your frequency? Are you getting more rest? Are you cleaning your hands with all that alcohol cleansing stuff because everyone's coughing around you, me included? What are you doing to increase your frequency for this holiday season? Remember, you have what it takes to be great. Thank you for tuning in to It's All About the Frequency podcast. I hope you enjoyed today's episode. Share it with a friend and remember to keep your frequency high.